Hi everyone, welcome to our grand rounds for October. My name is Annie Benzi. I'm the chair of the Fellow Subcommittee of the SSCT Complex GI Surgery Fellows Committee. I just want to welcome everyone, especially anyone that may be joining us internationally. We're very excited to have you. We have a great topic today. Without further ado, I'd like to introduce Dr. Matthew Katz, who has graciously volunteered to be our moderator. We're very thankful and excited to have you as well. Dr. Katz is professor and chair of the Department of Surgical Oncology at University of Texas MD Anderson Cancer Center. So take it away, Dr. Katz. If you wouldn't mind just pointing us towards this topic.
Thanks. Yeah, I appreciate the opportunity to join today, and I'm happy to help in any way I can get through this very controversial topic. I'm also happy to introduce Dr. Salah Jalil from Advent Health Orlando, who will be taking us through, I don't think cases, but I think some discussion. Right, Salah?
Yes. Correct, sir.
So why don't you start, and then we'll you may have questions for the group, or I can toss out some thoughts, and we'll just take it from there.
Okay. Thank you very much, everyone, for being here today. I'm Salah Jalil. I did my medical school in Egypt, and then I moved to the country. I did my general surgery residency in South Carolina, and currently I'm doing, as Dr. Katz says, I'm doing my fellowship at Advent Health Orlando. Today I'll be talking about the use of neoadjuvant chemotherapy in patients with resectable pancreatic cancer. I have no financial disclosure. And our agenda for today, I'm going to have a brief introduction about pancreatic cancer and some statistics, different classifications of resectable pancreatic adenocarcinoma, why we want to give neoadjuvant chemotherapy, and what are the advantages and disadvantages of neoadjuvant chemotherapy, and what's next, where are we going in the future. So it's expected that it's going to be 64,000 people will be diagnosed with pancreatic cancer in 2023, and approximately 10% of these patients is expected to live for the next 5 years or more due to the advanced disease. The use of neoadjuvant chemotherapy was pioneered in the early 1990s, and the name neoadjuvant was founded by 40 years ago, actually, by Emil Friel. Pancreatic cancer is on the track to become the second deadliest cancer in the United States, following lung cancer and replacing colorectal cancer by the end of this decade. So R0 resection is the best chance for long-term survival, but clear surgical margin, clear margin resection rates are relatively low due to early invasion of the tumor. R1 resection are constantly associated with worse outcome, and I think an efficient downstaging or downsizing the tumor preoperatively by a neoadjuvant chemotherapy could improve the R0 resection rate and potentially overall survival in patients with resectable pancreatic ductal adenocarcinoma. However, even after R0 resection, relapse rate is still very high due to local recurrence and metastatic disease, mainly to the liver and peritoneum. These are the different classifications to define what's resectable, what's borderline, and what's locally advanced. So this is from AHPPA, MD Anderson Alliance, and NCCN guidelines. For the celiac trunk, common hepatic artery, and SMA, they all share almost the same criteria, which is no abutment or encasement and no solid tumor contact with the artery. For the SMV and the portal vein, the AHPPA defined their criteria as no abutment or encasement or occlusion. The MD Anderson defined as abutment or encasement without inclusion, and the NCCN guidelines defined their criteria as no tumor contact or less than 180-degree contact without vein contour irregularity. So why we want to give neoadjuvant chemotherapy in patients with resectable disease? So there are studies done in genetic altered mouse models, and they use KRAS-driven pancreatic ductal adenocarcinoma. And when they test for pancreatic epithelial cells, they actually found these cells in the liver and circulation even before the development of microscopic tumor in the pancreas. Indeed, as many as 95% of patients diagnosed with radiographically resectable pancreatic ductal adenocarcinoma have detectable circulating tumor cells. Together, these cancer cells, which cannot be addressed surgically, account for high rates of local and distant recurrence. So there's several phase 2 trials testing newer chemotherapy regimens that's been successfully completed, but unfortunately they didn't find any statistically significant improvement in overall survival. Only a few phase 3 trials of preoperative therapies have been launched specifically in this group, which is a resectable pancreatic ductal adenocarcinoma. But the concern is that the risk of disease progression associated with delaying the surgical resection. I'm going to do some literature review. This is the first article I have is Pancreatic per day 48 study. This article was a prospective multicenter controlled phase 2 trial published in 2022. They enrolled 153 patients into 3 arms. Arm 1 was the neoadjuvant modified FOLFIRINOX. Arm 2 was the neoadjuvant FOLFOX, and Arm 3, which was the control arm, which is the upfront surgery. The FOLFOX Arm 2 was stopped earlier due to lack of efficacy when they did an interim analysis. Although data from the neoadjuvant modified FOLFIRINOX arm also provided no evidence of a significant increase in 1 year overall survival compared with the controlled arm. The resection rate were 74, 81, and 74, 68, and 81 in Arm 1, Arm 2, and the controlled arm, respectively. 1 year overall survival rate were 84.1, 71.8, and 80.8% in Arm 1, 2, and 3. And they defined events as any disease progression, metastasis, locally advanced, or death. And the 1 year event rate-free survival were 51.4 in Arm 1, 43.1 in Arm 2, and 41.7 in controlled arm. This is another article, the NewNAX trial. This is a prospective randomized phase 2 trial with 2 independent arms, which was published in 2022 in the Annals of Oncology. They involved 127 patients with resectable pancreatic ductal adenocarcinoma in 22 German centers, and were randomized in Arm A and Arm B. Arm A was 2 preoperative neoadjuvant chemotherapy and 4 cycles of adjuvant chemotherapy. And Arm B was consistently with upfront surgery with 6 cycles of adjuvant chemotherapy. 90% of patients in Arm A completed the neoadjuvant treatment, and 40% of patients in Arm B started the adjuvant chemotherapy. R0 resection was 88% in Arm A and 67% in Arm B, and the median overall survival rate endpoint was 25.5 months in Arm A and 16.7 months in the upfront surgery arm. This is the SWOG S1505 study, which is a randomized phase 2 trial with preoperative chemotherapy, 12 weeks pre-op and 12-week post-op with either modified FOLFIRINOX or gemcitabine with nab-paclitaxel. This article was published in 2020. They enrolled 102 patients, 55 in Arm 1 and 47 in Arm 2. And they found no significant difference in 2-year overall survival, 40 versus 48%. And there was a little evidence that either regimen improved the overall survival compared with the standard treatment. This article was done to see if there is any effect on pancreatic duodenectomy. Does neoadjuvant chemotherapy increase the mortality or morbidity related to the neoadjuvant chemotherapy when the patient undergo pancreatic duodenectomy? And this retrospective analysis actually was published in 2006, and they enrolled 79 patients with preambulary malignancies. And there was no difference in mortality between pancreatic duodenectomy after neoadjuvant chemoradiotherapy and conventional pancreatic duodenectomy. The only significant finding was the neoadjuvant chemoradiotherapy group had a significantly lower pancreatic leak rate than the conventional group, which is 10% versus 43%. Also, intraabdominal abscess formation was less in the neoadjuvant chemoradiotherapy group compared with the conventional group. So, what some of the disadvantages of giving neoadjuvant chemotherapy is that the 2 main concerns in pancreatic cancer is early systemic control and achieving R0 resection, which both can potentially be achieved with neoadjuvant chemotherapy. On the other hand, the missed opportunity to cure in patients with a disease, who have a disease progression during neoadjuvant chemotherapy because of delaying the surgery is an argument against this concept. Although which can be encountered by the view that these patients already have an aggressive disease, which probably have disease progression regardless of the surgery or not. Also, if we're going to start neoadjuvant chemotherapy, we have to obtain a biopsy. And this is not always a straightforward procedure. Sometimes we need multiple attempts to reach a definitive diagnosis, which will delay the surgery furthermore. And the complication from neoadjuvant chemotherapy is a possible cause of delaying the surgery. This article, The Fate of Resectable Pancreatic Adenocarcinoma After Neoadjuvant Chemotherapy, this article was published in 2022, and they collected data between 2018 and 2020. They enrolled 66 patients with resectable disease and underwent chemotherapy. In arm 1, they underwent folinic acid, fluorouracil, irinotecan, and oxaliplatin, and the other arm was gemcitabine-based regimen. Following restage in 47 patients, which is 71% of the total patients, were thought to have resectable disease, and 36 patients underwent resection to date. Metastatic disease, unfortunately, was found in 12 patients, which is 18.2%, and 9.1%, which is 6 patients, had locally advanced disease. So where are we going next? So pancreatic ductal adenocarcinoma represent a phenotypically variable group of malignancies arising in physiologically diverse patients. I think by moving away from classic anatomical description to more nuanced landscape of biomarkers predictive of tumor behavior and response, we can further refine the question asked in preoperative trials and translate the answer in clinically meaningful precision therapy in pancreatic ductal adenocarcinoma. These days, most of the radiographically staging systems does not take into account other prognostic factor of pancreatic ductal adenocarcinoma, such as patient's physiological status, biological characteristic of the primary tumor, and any radiographically occult disease that might exist below the limit of detection on routine imaging. So genomic determinants and alteration. So as we know, the most common altered gene in pancreatic ductal adenocarcinoma is KRAS, which is mutated in about 19% of the tumor, followed by P53, which is 80%, and SMAD4, 40%. Other less common somatic alteration in genes such as ATM, BRCA1 and 2, ALK, which increase the risk of pancreatic ductal adenocarcinoma and represent potential therapeutic targets. Transcriptional subtype. So, excuse me. Beyond germline or somatic genetic alteration, transcriptional gene expression of phenotypes may predict the behavior of pancreatic ductal adenocarcinoma. So there is a recent study, a recent analysis done by the Cancer Genome Atlas, and they classified pancreatic ductal adenocarcinoma into 2 types, classic and more basal-like type. And when they compared the classic and the basal subtype, they found that the classic type have more JATA6 expression compared to the basal-like subtype. And basal-like, due to lack of this expression, it was found to be more chemo-resistant than the classic subtype. And there's subsequent studies that validate the use of simple tests such as high JATA6 expression on in situ hybridization or simplified gene classifier to differentiate into the 2 subtypes. So microbiome. So there is a recent study performed at MD Anderson, analyzed tissue from long-term survival of pancreatic ductal adenocarcinoma, and they compared it to short-term survival. And they used S16 ribosomal RNA, and they found a greater diversity of the tumor microbiome was found in long-term survival. And a specific microbiome signature was highly predictive of long-term survival. Now, these studies were used after that by doing a fecal transplantation from the human long-term survival into genetic altered mouse models. And they actually found that there is a change in the tumor activity and growth and the immune infiltration. Currently, MD Anderson is still enrolling patients in phase 1 of preoperative fecal microbiome transplant study to assess the safety and feasibility. So in conclusion, this topic is neoadjuvant chemotherapy in resectable pancreatic cancer is still debatable. The 3 main concern is early diagnosis of cancer, early control of micrometastasis, and achieving R0. I think in the future, further like genomic sequencing, transcriptional analysis, and tumor microbiome play a major role in identifying the different type of cancer and which one will benefit from neoadjuvant chemotherapy instead of undergoing upfront surgery first, as these 10% of patients who with resectable disease may progress while they're on adjuvant chemotherapy and miss their chance of having resection, which known to increase the overall survival over time.
Great, thanks. A lot. Appreciate you putting that together. Nice set of slides. Maybe first of all, I can ask if anyone has any questions, and then, you know, you covered quite a bit. Maybe we can kind of start at the beginning and go through some particular points that I think are worthy of emphasis, since you covered, you know, about 4 decades of work in about 20 slides. So I think there's some things that we can hone in on. Does anyone have any questions, first of all, for Salah? Okay, why don't you go back to why don't you start at the beginning, and let me just go back. Yeah. Okay. All right. Okay. Go. Yeah. Keep pushing forward.
Mm-hmm.
Yeah. Keep pushing forward. Yeah. Keep pushing forward. Okay. Stop here. All right. So you put this slide up. No, the previous one, the staging one.
Yes.
You put this one up because you were in a talk about neoadjuvant therapy. Tell me what kind of you were trying to get at here. What were you implying that? How can staging be used to influence whether or not neoadjuvant therapy is administered?
So the current staging depends on radiographically picture of the patient. It doesn't take into account anything else. This slide was placed just to see the different categories or the different criteria to define resectable disease, which doesn't include anything else other than radiographic or CT scan imaging or MRI imaging for the patient, and classified if it's related to the artery or the vein or not. It doesn't involve anything from the CA19-9 or physiological status of the patients or the biological characteristic of the tumor.
Yeah. So what is it? So when you're talking about resectable and things, what does that even mean? So what does it mean for a tumor to be resectable? Anyone?
So you asked me or anyone? I'm sorry, I didn't hear.
Anyone.
So for a tumor to be resectable, it means that the mask is be able to removed with ability to reform reconstruction of the vein or the artery.
No, that's not what it means. Anyone, what does it mean? When a tumor is resectable, what does that mean?
Dr. Jacob, would you like to weigh in?
It's not a trick question.
I mean, if you can achieve an R0 resection, depending on tumor abutment to the vessels and so forth.
Yeah, so I would say part of it is, you're right, part of it is getting a clean margin. And what is the other really important part? Kind of guess what I'm thinking maybe, but.
Is it getting them through the operation in order to them to get adjuvant therapy?
Just getting them through the operation, right? So for a tumor to be resectable, just again, this isn't a trick question. It means you want to be able to remove the tumor completely, and you want to be able to do it safely, right? So that's one of the key issues with pancreatic cancer staging as we know it today. Is it kind of addresses the first issue, but it doesn't address the second issue, right? You can get a negative margin on anyone, right? I mean, there's not a tumor that exists where you couldn't get the tumor out with negative margins. Patient would be pretty unhappy in many cases, but it's always possible, right? So it's really important to consider whether or not the operation that you're doing is safe to do, and it will, the patient can come out of it and live the life that they want to live. What's another thing that needs to be considered, but that's particularly important for pain? Is it really possible based on what we call R1? Rohan,
I
want
just
to
had to
elaborate?
throw that in, Dr. Katz, because we
Yeah.
pride ourselves in margins in the US, but the Europeans actually pride themselves in a high R1 rate, right? Because they say that the pathologists are spending more time on the specimens, are inking separately. We actually 5-color ink. So I just wanted to bring this up because I think R0 is not as easy as it seems, right?
Yeah, correct. And I think what we're talking about here is the fact that for pancreas cancer, the likelihood of clearing cancer from the body with a knife and string, the likelihood that that happens in any patient is extraordinarily low. Whether that be leaving residual disease in the tumor bed, or whether it's leaving residual disease, circulating and in the liver. So I guess that's all to say that, these definitions of resectability are merely guidelines, and they really only can be used to describe whether or not, a margin negative resection is possible, but it says nothing. They say nothing about whether or not an operation can be done safely, whether or not residual disease will exist either in the tumor bed or elsewhere, whether or not the tumor comes back. So, I think these, these definitions are important, but I think what Dr. Jalil was trying to explain in this talk is that, ultimately these are of limited value, and as we gain greater understanding of the biology of pancreas cancer over time, these will probably become less and less relevant. So I wouldn't certainly memorize these. I would just know basically that, resectable cancers are ones that you can remove and potentially get an R0 margin, potentially. Borderline resectable are generally ones where getting an R0 margin in the absence of any preoperative therapy is extraordinarily unlikely. And then locally advanced are tumors where, it's virtually impossible. But again, these classifications don't really describe what is happening with pancreas cancer in general, and therefore the extent to which they should be used to determine what treatments people get is debatable, right? So I think what your point was, Dr. Jalil, was that for resectable cancer, so if you have a resectable cancer based on these criteria, what did your literature review tell you about how that patient should be treated?
So
a patient with a resectable tumor.
So it depends. If it's a resectable disease, the guidelines is to proceed with surgical resection. That's the standard treatment currently. So to proceed with surgical resection if the patient can't tolerate the surgery, and followed by adjuvant treatment. That's the standard.
Okay, so what guidelines are those?
There's the NCCN guidelines.
Yeah, so NCCN guidelines are patient with a resectable tumor. Now tell me what again, what?
If the patient had resectable disease and they're fit to proceed with surgical resection, they should have upfront surgery and then followed by adjuvant treatment.
Okay, and then for what do ASCO guidelines say?
What?
ASCO guidelines.
I can't hear, I'm sorry.
ASCO guidelines. So there are other guidelines. I just wanted to just bring that up. And,
Yeah.
you know, generally it's true for patients with, anatomically resectable cancers, it is worthwhile considering surgery followed by adjuvant therapy. And what's the data that informs whether or not surgery followed by adjuvant therapy will be effective? What are some data that you can cite just briefly, because I know this is a pre-op therapy talk?
I don't know. I'll have to go back and look into some data to see which one is outside of.
So anyone tell me a relatively recently performed phase 3 trial that looked at patients who undergo resection who receive adjuvant therapy with resectable cancer.
In the interest of time, Matt, do you want to just fill us in on what you're referring to?
I guess so. There's patients who do undergo resection should receive adjuvant therapy. That's based on data where patients were randomized to undergo surgery alone versus surgery followed by chemotherapy back in 2008, I think, in Conco 001. And patients who underwent surgery and received adjuvant therapy did significantly better. Recently, a couple of years ago, 3 years ago, I think, there was a study which randomized patients following resection to receive either gemcitabine or FOLFIRINOX, and patients who were randomized to receive FOLFIRINOX after surgery did really well. They lived a median of about 5 years. So the long story short is, if you have a patient who has a resectable cancer you think can get through an operation and looks like patients who would be anticipated to receive FOLFIRINOX postoperatively, that is a reasonable approach. In my view, patients for whom there's ambiguity about whether you can get them through an operation successfully, whether they'll recover completely to be able to receive adjuvant therapy, et cetera, then those patients should receive preoperative therapy, irrespective of what their tumor anatomy looks like. All right, let's keep going through these slides. So, okay, keep going. Keep going. Okay, so these two, and we'll get to Ryan. Hey, Ryan. We'll get to Ryan's question in a second. But so these two studies you pointed out were two phase 2 studies that were recently published that randomized patients to primary surgery followed by adjuvant therapy versus neoadjuvant therapy, right? But there were a couple. There's been a couple of other relatively small studies that have also looked at this issue and have been that have suggested the opposite, right? So there was a recent study out of Norway that was published, that was reported, it hasn't been published yet, where patients were randomized to receive preoperative FOLFIRINOX versus surgery and postoperative FOLFIRINOX, I think postoperative FOLFIRINOX. And in that study, the patients who underwent surgery first actually did better than patients who received preoperative therapy. So I would include that, and I don't think it was a great study, but I do think that it points to the fact that, you know, there is still ambiguity with respect to the value of pre-op therapy here. You only showed positive studies, but there have been at least one, and I think 2 negative studies. Again, I've used only tumor anatomy, but let's look at some questions here.
Some deeper questions over here, Dr. Katz. When you look at these studies, as you know, there's a whole mishmash of what's called anatomically resectable versus borderline resectable. And I think one of the purposes of this talk is really, I think Dr. Jalil was wanting to get at, in truly resectable patients, do you think that we have data that looks at this effectively?
So in resectable patients, do we have data that
looks at the
informs whether or not we treat them pre-op or post-op?
Correct.
Yeah, he's presented 2 studies here. Again, there are several other studies that randomize patients between those 2 treatment schemas, but I think the long story short is that, here's my personal bias, is that it's kind of a silly question, right? This whole concept of pre-op versus post-op therapy for groups of patients selected only on the basis of what their tumors look like is a ridiculous question. Because I think, again, I think tumor anatomy for patients with pancreas cancer is not the most important issue, because like Salah pointed out, most of these patients, irrespective of what their primary tumors look like, they have cancer elsewhere, right? And just like you pointed out, doesn't matter if their tumor is resectable and we think we can get an R0 margin. Probably we're just not looking hard enough, and we're not getting an R0 margin. So, tumor anatomy is interesting, but that is really not the most important thing. So I think just having a question, should all patients with resectable pancreas cancer be treated pre-op or post-op, I think is a ridiculous question. I think the things I think about when I'm looking at a patient and determining whether or not a patient should receive preoperative therapy or postoperative therapy are exactly the things we've talked about. So first of all, I would look at their primary tumor and decide, what is the likelihood I can clear this to a margin that at least resembles an R0 margin. So that's the first question. The second question is the operation that I would do achievable in a manner in which the patient would not only survive the operation but thrive postoperatively? And the third question I ask is, what is the likelihood that the patient will recur following surgery based on everything we know about the tumor? So CA19-9, what is that? If the patient has a CA19-9 that's extraordinarily elevated, I think again the tumor, the anatomy of the tumor is pretty irrelevant. If there's regional lymph nodes that are clearly involved radiographically, or sometimes we see those echoendoscopically, those are patients for whom prognosis is not so hot. I would prefer to use to administer some preoperative therapy. Do I think that there's data that tells people what to do under each and every given circumstance? No, of course not. But you have to think about things and the individual patient and take what you know from data that exists and extrapolate that to the patient you have. People still think that we give, only preoperative therapy at my institution, and certainly we give a lot, about 80% of patients we give preoperative therapy to, but we still operate, about 20% of the time. And those are patients who have, small, technically resectable cancers, super healthy, thin. They're going to coast through the operation. Their CA19-9 is low, and they're anticipated to look like patients who were enrolled on the study that I mentioned, where patients received postoperative FOLFIRINOX. Ryan Day asked, are we good at selecting patients when 50% of patients don't receive chemotherapy on time? I would say there's patients for whom, recovery is ambiguous, and there's patients for whom recovery is pretty straightforward. If you have a young, healthy, thin patient with a tiny tumor, the Marge duct, chance of leak is low. The likelihood that you will get that patient through an operation and they will recover sufficiently to get postoperative chemotherapy when the operation is done at a reputable place is super high. The more I'm concerned about a patient's recovery, the more I would recommend pre-op. Z, how common is it that medical oncology would be willing to administer chemo in the absence of tissue diagnosis, despite many attempts, but with high degree of suspicion for upfront resectable pancreatic ductal adenocarcinoma? So Z, kind of tell the group what you're thinking here.
I think I'm trying to get to the point that if you believe that neoadjuvant systemic chemotherapy is the right first move for upfront resectable pancreatic cancer, but you try to get tissue diagnosis and you cannot get tissue diagnosis, I'm just curious to find out, because I think it's mixed between institutions. How common is it that your medical oncologist would still be willing to administer chemotherapy versus insisting that they will not, based on the fact that you do not have a tissue diagnosis?
Yeah. So I think it's a very good question. You're exactly right that it is institution dependent, and in some cases, I would say medical oncologist dependent. The issue for the trainees is that, while it is perfectly appropriate in some settings for a surgeon to operate on a patient for whom a tissue diagnosis has been elusive, medical oncology in general will not treat without a tissue diagnosis. And I think there's some good reasons for that, right? They don't know exactly, if you have a hypodense mass in the head of the pancreas, that could be pancreas cancer, but it could be many things. And not only could it be pancreas cancer, but it could be a variety of different histopathologic subtypes of pancreatic cancer. And, it really is helpful for medical oncology to know what they're dealing with in order to prescribe the right chemotherapy. Now, there's some situations that Dr. Fong is talking about where, you do an echoendoscopic biopsy once, twice, maybe even 3 times, and you can't get a tissue diagnosis. So I think in that type of situation, there's a couple of alternatives. If the patient is, if the diagnosis is reasonably clear, CA19-9 is high in the absence of jaundice, older patient, hypodense mass looks characteristic, and the operation is safe, and you think you can get them through a operation very safely, I think it's appropriate to operate on that type of patient. If you want to administer preoperative therapy and you can't get a tissue biopsy, what we have done at our institution is a couple of different things. The first is all those cases are presented at our multidisciplinary conference. So I would say that you have to have group consensus in a situation like that. And if we get group consensus that a radiographic lesion is adenocarcinoma, then we have proceeded with chemotherapy in that type of case. The other thing we've occasionally done is that's the main thing is just getting consensus. I'll leave it at that. But I think, you don't want to keep poking and prodding at tumors repeatedly. If you have tried to get a biopsy at a reputable center and you still can't do it, then you have some choices to make. What are some other things you'd want to rule out in that type of situation? Anyone? Obvious benign etiologies.
Neuroendocrine tumor.
Yeah, neuroendocrine tumors are typically, autoimmune. That's the big one, right? IgG4. So not sure that I'm good calling adeno on scan. Yeah, sometimes it's relatively straightforward, but sometimes it's difficult, and that's the issue, is that sometimes it can be difficult. If you have a patient who's a young patient with a normal CA19-9 and a hypodense mass, that's a pretty atypical presentation, particularly in the absence, say they aren't jaundiced, they have a tail lesion, for example. Those can be pretty difficult sometimes.
Yeah, I just
you have to trust your radiologist.
I just want to kind of jump in that and just state, I think one thing is being not in a cancer center changes one's perspective quite a bit. Because, when you have somebody with chronic pancreatitis and a mass-looking lesion, it can look a lot like cancer. So I do think we need to just keep balanced over here, because I think you're kind of at the tip of the funnel here, seeing, some people that have gone through quite a bit before they get to you. For us, in sort of in my world where many of my patients can't afford the bus ride to Houston, where we're sort of stuck having to deal with some of these things. So I just want to say, I think it does become a little bit challenging. And you're also dealing with radiologists that may not be as well versed as your body images are, that type of thing. So just throw that in.
Yeah, point well taken. So what do you do in your institution in that type of situation? 19-9 normal, young patient, could be chronic pancreatitis. What's your approach?
So I think, we always have this issue of, is it autoimmune pancreatitis? Some people advocate just a trial of steroids. As you know, Suresh Chari at Mayo, when he was at Mayo, he's now with you all, would advocate a trial of steroids and seeing if the stricture goes away. And I think that that's not wrong. I don't think you're going to increase your morbidity with the Whipple with a short course of steroids. I think other things, it really depends, as you said, on your endoscopic person, because core biopsies are really helpful in this circumstance. And then I think, the ones that we have the greatest issue with are, obviously when there's a lot of acute pancreatitis in the face of everything, which is pretty unusual for a straight cancer. I think in our world, the medical oncologist will not treat without diagnosis. And I think, I'd love to find out what others on the call, Sebastian, what happens in your world?
Yeah, I mean, I agree. We are surgeons, and therefore, we'd like to operate. I think that if someone has multiple biopsies, 4 biopsies, understandably, at some point, if they do have jaundice, you have to decide whether that patient needs to be taken to the OR. The question of tumor board, I think that's a key question, the key point. Because if you were to have a complication after a Whipple, well, you have consensus, so I think that's tremendously important. I haven't done a first biopsy, but in the old days, we used to do first biopsies. And that's another option. But certainly, if you have multiple biopsies and you continue to have clinical concern, at some point that patient may have to be taken to the operating room and have a resection that would be both therapeutic potentially and diagnostic.
And I think ultimately what we do, Matt, is they go to the operating room if it's resectable in any way, and at least for tissue diagnosis. But I agree with you, it's really hard when you've got somebody who's not clearly resectable, obviously, to take them to the operating room in this circumstance. I just have been burnt, obviously, with neuroendocrines, and they of course are not going to respond, or in cystic lesions too, as you know well, they don't tend to respond well to upfront therapy.
Agree. What else can we talk about here? Keep going on your.
Oh, I still want to kind of put you, I still kind of want to put you on the spot, Matt, because you did mention that, because, you know, clearly you're sort of known as the neoadjuvant guy, right? And so let's just kind of, you know, you're saying though, if somebody comes in with a T1, N0, M0 resectable pancreatic head cancer, and you have a tissue diagnosis, you would consider not giving that patient chemotherapy and going straight to the operating room if you think they can get them through surgery well and to adjuvant treatment. Is that a reasonable statement?
That is 100% correct. Yeah,
Okay.
absolutely. So the
And-
best.
Go ahead.
No, the best data we have is that PRODEUCE study, again, which randomized patients post-operatively to gemcitabine or FOLFIRINOX, and patients who received FOLFIRINOX lived a median of 50 months. Now, that does not mean that every patient who walks through the door should go to the operating room, because that trial showed that patients who got resection and received postoperative therapy live so long. But it does mean that if you have a patient that you think could get through the operation and look like patients who were in that accrued to that study and enrolled to that and received postoperative chemotherapy. So every patient that was enrolled to that study had already undergone surgery and recovered, right? So it's not every patient that walks through the door, but if your patient is young, healthy, looks like they could make it through an operation and recover sufficiently to get postoperative therapy, I would operate on that patient, absolutely. And I do all the time. Now, what is the of the denominator of people that come that have anatomically resectable or pancreas cancers? What is the percentage of patients who could reasonably look like that? So what is the percentage of patients that are healthy enough to undergo surgery immediately, number one? What is the percentage of patients that have a relatively low CA19-9? So patients enrolled in that study had a CA19-9 cutoff of 180, I think. So, you know, patients who have come to you who have a CA19-9 level of 10,000, obviously I wouldn't operate on. But yes, a patient who's healthy, I think could get through the operation well, has a low CA19-9, technically resectable cancer, I would absolutely offer surgery, or at least consider it. I think there's some patients for whom, to me, the role of preoperative therapy is clear. And then there's some patients for whom the role of preoperative therapy is less clear. And I think for patients who are not really well enough to undergo an operation right away, need some exercise, need some physiologic optimization, patients who have a high CA19-9, those are patients who are not going to do well with surgery. Now, will they do well with chemo? I don't know, but they probably won't do well with surgery. So I would treat them with preoperative chemo. But for patients who are for whom surgery is straightforward and 99 is low, etc., I think operation is perfectly reasonable given what we know, given the data that we have.
Thank you very much for that. So Dr. Katz, I think one thing to ask you is in the adjuvant setting, would you now consider that naleninox or whatever is with nab-paclitaxel, with Onivide should be used instead of FOLFIRINOX?
No, FOLFIRINOX is the. I don't. The answer is no. That's a very expensive drug. There was a recent study showing some potential benefit, but very expensive, probably more or less the same. To me, not a whole lot of rationale for using it, and at our center we wouldn't use that routinely. For us, it's FOLFIRINOX. In the adjuvant setting, it's FOLFIRINOX if they can tolerate, Gemcape if they can't, gemcitabine single agent if they can't even tolerate that. That's basically the
And you would not use Gemabraxane.
I mean, sometimes people do, but the data is not. Unfortunately, the data is not particularly clear for Gemabraxane that it's particularly effective in the adjuvant setting, even though it probably is. But no, in general, we don't typically use that in the adjuvant setting. I don't think personally that it would be wrong, but we don't typically know. I don't know if we have a medical oncologist on the call.
Dr. Benzie, do you want to open up for questions at this point, or what do you think?
Yes, please. So just going to put my ethicist hat on here a little bit too. So obviously we've all had that patient that, we tell them they need chemo first and they're like, I'm never getting chemo even if my life depends on it. And I'm just wondering if you've ever been in that situation where you're really convinced that someone needs neoadjuvant and they're just refusing adamantly, but they want surgery. Have you ever been in that setting, and how do you handle that ethically? And that can be for anyone that's been in that situation before as well.
I'm happy to give my answer, but if there's someone else that has an answer first.
Could we ask any of the faculty on the call to comment on that, perhaps? Dr. Osman? He's choosing not to answer.
The other Dr. Iswandu Sakandi.
Dr. Sakandi or Dr. Ross, what do you do in that circumstance?
There are a lot of patients who come to our office in Tampa, and they actually, because these patients are quite sophisticated, they already learn about you. They have a CAT scan, they have all information. Many times they get the EUS biopsy from the oncologist, and what we've seen is a lot of patients that come to the office, they're looking for surgery. So, obviously our job sometimes is a bit hard, difficult in this situation, but we try to give the best, the decision we can. But I have to say though, it is very common, especially in the non-university setting, when the patient come to look for HPV surgeons, they know what they want to get, and many patients not just they want a Whipple, they want a robotic Whipple, not just a Whipple. If you tell them we got to do open Whipple, they're mad, So there's like several stages, but this is a very common scenario, which is sometimes difficult to answer.
So Dr. Katz, I sort of put this with our trainees. I always say with every disease process, you've got to think about surgery, radiation, and chemotherapy, and say which of these is your biggest bang for the buck. I know that's very simplistic, but what do you think?
Yeah, I think it's chemo. So I think this ethical question is an important question, and there's some nuance to it. So the first thing I would personally say is, if a patient tells me they do not want chemotherapy at all, I think it is unethical to operate on them. I feel strongly about that, because the data is that patients who undergo surgery alone recur within 9 to 12 months. So I do not personally think it is ethical in most cases, unless it is really straightforward and the patient is super healthy. I would question the ethicality of operating on a patient if they refuse surgery at all. Now, meaning I don't want refuse chemo at all. Meaning I don't want chemo either before or after, right? Then I tell them, go find another surgeon. I can't think of a time that's ever happened, but that's what I would tell them. If they're willing to get chemotherapy, but they just want their tumor out and after, I agree. I think you got to do what you think you certainly have to take the patient's wishes into account. But I think it's our responsibility as surgeons to help them arrive at a answer that is well informed and is not based on emotion. And in my personal experience, I can count the number of patients who have come insisting on surgery and then have left when I've told them no. Like I can't, maybe one or two in my career. I mean, it just doesn't happen, because I think you have to sit down with the patient and explain, what you think is best for them. Now, again, there are cases where where the right path is ambiguous, and in that type of case, of course, you take the patient's wishes into account more than you might if, patients in a wheelchair, 19.9 is 20,000, and tumor is, abutting the SMA. I don't care how much they want surgery. They can either go elsewhere or, but it's not going to be me. So I think that it's an important question, but I don't think the answer is, patient wants surgery, okay, I'll operate. I think that's too simplistic. And most patients, at least that I've encountered, are thoughtful enough to think through all their options that you've laid out for them and can arrive at a solution that makes sense.
I think it's the responsibility of the surgeon to guide the patient into what they need to have. And in my opinion, until we prove that there's more chance of cure with something like neoadjuvant first, I'm of the belief that you do and offer the operation so you can treat more patients, as was nicely presented by the fellow. You're never going to get to the same number of patients offering neoadjuvant first, because they're not going to tolerate it. You know that that's going to happen. I mean, it's a given. It's tough. Chemotherapy is tough. But as surgeons, let me tell you, I can sell just about anything to a patient. Even if they dying to have it operation, I can sell a radiation, chemotherapy, or an operation. They listen to you, and the more convincing with information that you deliver, they're going to follow. But what do I believe will offer them the best treatment, especially if it's resectable, obviously not involving the vasculature, is chemotherapy, is an operation followed by always 100% adjuvant chemotherapy, and sometimes even radiation. But for me, I don't think it's a problem to sell just about anything we think of. Patient think they want an operation and they shouldn't have an operation. It's the surgeon's responsibility to guide them the right way, but they'll follow. Rohan, what would you say to a patient?
Well, again, I think sometimes delays in treatment are some of the greatest problems. And so I do think, I mean, Annie can tell you from, Dr. Benzi can tell you from working over here, we're pretty aggressive with upfront surgery here. But I do think that I agree with you, Dr. Katz. I think absolutely they need, chemotherapy and surgery. The question is, if you were to go on randomized prospective data, our best data is in the adjuvant, unfortunately, at this point.
Agree.
Yeah.
Also,
Sorry, go ahead, Dr.
When you look at the robotic outcomes versus open, patients actually do much better in the world, and we're just now trying to figure out why. They live longer, they recover faster, they go home sooner, they start chemotherapy sooner, they tolerate the heaviest chemotherapy, the FOLFIRINOX afterward, when compared to others that we had when we compared it to the open outcomes, and that's of all comers. And so,
and I think, Dr. Ross, I would really think you should publish that, because I think that this is something
we're trying.
I personally, I have not been as impressed with my personal outcomes with robotic Whipple, but that's just, I think, my fault, not anything else, just to be frank. I actually find that if the nicest robotic Whipples are the worst leaks ever because they're not contained. So I really think you guys should be leading the way here. But I do think, I do think that there are many ways that we can make this a safer operation is the key issue. And I think just to answer this question, Dr. Katz, for community general surgeons, what would you like apart from stop, pack it up, and send it to somebody who does this a lot, right?
I'm not sure I understand your question.
So if somebody shows up in rural Texas with a mass and painless jaundice, what would be your best advice to the surgeon that's consulting?
Yeah, unanswerable, but we need more information. But in general, there's definite value in surgery. Of course, there's value in surgery, but surgery has to be utilized thoughtfully in the context of a multidisciplinary plan and implemented and administered to patients who are likely to tolerate it and are likely to receive all therapy. So, yeah, I mean, an incredibly complex question. Obviously, a lot of different, views on the role of surgery for pancreas cancer in general, the role of pre-op therapy, et cetera. I think we all agree that that surgery is the right thing to do for at least some patients. The question is, how do we select those patients who are best going to benefit? And I guess I'll leave it there.
Dr. Welsh, I'd just say, key thing, surgeon who does this all the time needs to see the patient, I think, and drive the decision tree here.
Excellent. Well, thank you all much. Thank you all very much for this very intriguing discussion. If you wouldn't all just mind putting on your cameras for a second so I can take a screenshot so we can tweet out, just let everyone know what we did tonight. And again, thank you so much, Dr. Matthew Katz and everyone that participated and our fellow Dr. Julia for putting together that presentation. Here we go. So everyone, I bet a smile. Give me 1 second. And other than that, please join us again next month. We're going to have another one of these in November. And the topic is actually esophageal conduits, alternative esophageal conduits for reconstruction. So thank you all and have a great evening.